So it is important as any cardiologist, it is not just the patient who is coming with a intervention hitting on the face. No, the patient will present either with congestive heart failure, a shock, cyanosis, or a murmur. But he will have one of these congenital heart diseases. Either he will have a shunt lesion, or there is obstructive lesion, or there will be cyanosed. So when do we have to intervene? We have to intervene where we realize that the natural history will benefit the patient. That is the whole intention of deciding the need for intervention at the appropriate time. So what do we need? A complete correct diagnosis before we really come to the point of the indication of surgery. And why appropriately? This is something which many of us actually face, the problems of late operation. The late operation, immediately post-operative, they have delayed recoveries and complications, and long term, they have non-regression of PVRs and ventricular dysfunction, and that is why they need appropriately timed surgeries. So for a congenital left to right shunt lesion in general, for any left to right shunt lesion, the indications are if the patient is persistent in congestive heart failure, the patient is having failure to thrive, the PA pressures continue to be almost systolic or nearly systemic. This is a general indication. Now coming to specific, pre-tricuspid shunt, such atrial septal defect. The elective closure is needed whenever the shunt is more than 1.5:1 and the RV volume overload. So once you get a RA and RV volume overload, this becomes an indication for surgery. The timings as per the guidelines is 2 to 3 years of age. Surgical, definitely a primum ASD, a sinus venosus ASD, and a fossa valis ASD, which has got inadequate rims, would be a clear indication for a surgical closure. For a device closure, adequate rims and all the other criteria for increased volume on the RA and V, such as RV volume overload, and provided rest of these systemic pulmonary veins and systemic veins are draining normally. So once you send it for surgery, it is very important that you evaluate the pulmonary veins, you evaluate the neglected left side. Why I say neglected? Because most of the time our concentration is on the ASD and the RA and RV. Whenever you are sending a pre-tricuspid shunt, always evaluate the left-sided lesions for mitral stenosis, for pulmonary veins before you send for surgery or an intervention. Device closure is I got a high success rate, minimal complications, and apparently I would say even the surgical results are almost the same. But what is important is the appropriate patient is referred appropriately. Coming to ventriculoseptal defect, post-tricuspid shunt, the ideal time is 3 to 6 months of age. Most of the time, it is a single corrective surgery. And well, if there is multiple surgeries, one might go for a PA bending. The indication is a persistent CHF, poor weight gain. In spite of optimization of decongestive therapy, I would err towards earlier, maybe 3 months. But if I can optimize the therapy and make it almost 6 months of age, that would be better. Electively, the VSD may require closure when there is associated AR, associated development of gazules, that is pulmonary stenosis. Definitely, a shunt which is less than 1.5:1 with no PH and CHF does not warrant closure, be it surgical or a device. For a device closures, muscular VSD is a very good. Post-op is obviously a better choice. And a perimembranous CSD, if we have got adequate selection criteria and we have got a rim and we are sure that we can be away from the aortic valve without causing heart blocks, these are amenable to VSD device closures. Not to be operated are very small VSDs with no pulmonary stenosis or PH, and of course a VSD which has already got Eisenmengerized. Dr. Shija in previous slides has beautifully shown how to decide about Eisenmengerization, PA pressures being high, and VSD, one has to be very careful, particularly if the patient is presenting late. You have to adjust whether there is a volume overload on the LALV, is the LALV still dilated, is the QP significant enough, and if in doubt, always subject to cardiac catheterization before sending for surgery. For PDA, the elective closure is generally 6 months to 1 year of age. Or at the time of presentation, if you think the patient is symptomatic. How early we can close? Now with the development of newer piccolo devices, preterm devices, we are closing as small as 700 grammer PDAs easily. But only if it is indicated. For a preterm small PDAs, high flow PDAs, PDAs which are stealing from the systemic circulation into the small primies lung bed. The blood is getting stealed across the PDA into the lung bed, that is the indication. For rest, if there is a secondary LALV volume overload or if the PDA is not a silent PDA, then probably in view of high risk of infective endocarditis, this becomes an indication for closure. So we can close any PDA of any size with a device. Well, for a large PDAs where we feel that a device might impinge on the adjacent structures. Adjacent structures are left pulmonary artery and the aorta. If they are impinging on the adjacent structures, our device is going to cause long-term problems. It's a very good and safe idea to send for surgery. Remember, surgery is a very good alternative. But of course, if you feel that our device is going to cause complications, is going to be a very big device, is going to impinge on the adjacent structures, surgical option is always a good option. Now coming to AV septal defects. Now for AV septal defects, when the VSD is large, the patient continues to be on congestive heart failure in spite of optimization of the decongestive therapy. This particularly happens when there is a significant associated AV valve regurgitation. So because of the regurgitation, the CHF gets exaggerated. And once that exaggerated, you might have to go for early surgery. This could be as early as birth also, but we would like to delay, preferably at around 2 months of age. For a large ASD with a restrictive VSD, it's like a pre-tricuspid shunt. We would like to wait almost till 1 year of age. With a pre-tricuspid, we can wait almost 1 year or 2 years of age. We have come down on the age with more and more surgical skills which are now there. For obstructive lesions, late intervention will cause either a stress on the heart leading to myocardial dysfunction or would cause a residual hypertension such as in case of coarctations. So they need to be acted early. For a right-sided pulmonary valve stenosis, a gradient of more than 40 is now an indication. For infundibular PS, a gradient of more than 30 is definitely an indication. And most of the time, infundibular PS would respond better with a surgical measure than, while a valvular would be a better choice, would be a percutaneous or a balloon dilatation. For a left-sided obstructive lesion, I'm talking of isolated lesion without associated symptom. If they are symptomatic, we are not going to go for gradients. If the patient is symptomatic, is caused ventricular dysfunction, remember any particular obstruction needs to be tackled. And if the horse is not able to move well and it's got so much of a strain, we have to remove the strain, and the strain is the obstruction. So obstruction needs to be relieved whatever the age if there is a associated ventricular dysfunction. In the absence of ventricular dysfunction of symptoms, any asymptomatic gradient of more than 64 is an indication as per the newer guidelines for aortic valve, and a peak to peak gradient of 50. Remember, peak to peak is a cath lab gradient. So practically, we will be either a 40 mean on echocardiography or a 64 mean or 64 peak on echocardiography. For a subvalvular gradient, more than 50 becomes an absolute indication. But remember, associated aortic regurgitation for a aortic valve which is constantly hitting the aortic valve and causing the injury, onset of AR, it's itself an indication to save the valve to go for early surgery. For a coarctation, a gradient of more than 20 or any coarctation which is symptomatic in the form of systemic hypertension, LVH, secondary complications would need a surgical intervention, or a surgical intervention if the patient is less than 6 months of age for a coarctation. Beyond 6 months, I believe a ballooning or a percutaneous option is a better intervention. Of course, 3 months to 6 months is a gray area and depending on the institutional policy. Now coming to last part of the thing is this cyanotic congenital heart disease. So why a timing of intervention for a cyanotic congenital heart disease? If we delay, it leads to poor development, problem related to polycythemia. So it is important that we act early. Remember, an X-ray like this with a black lung field, no cardiomegaly, a tetralogy, one should be very cautious, and clinical findings which are showing you ejection systolic murmur is probably a tetralogy. And immediate intervention is needed whenever there are repeated cyanotic spells. The saturation is less than 70%. The hemoglobin continues to rise and the PCV is high. This is telling you that probably the patient is having a significant right to left component, significant cyanosis and secondary effects, and needs to be tackled. For us, since it's a fellows course and I thought it is important that the cyanotic spells are known to everybody. When to intervene is important. For adequate anatomy, it's an institutional policy. Now we are in fact operating even in infants. But yes, our institutional policy is still around 6 months of age. We would like to wait. And if there is a hypoplastic annulus with a coronary which is crossing the RVOT or maybe a need of a conduit, we would actually wait till the child grows to 10 kgs if it is possible, or a BT shunt if it is earlier. So palliation is either in the form of a BT shunt, a PDA stenting, balloon dilatation of the right ventricular outflow tract, or stenting of the right ventricular outflow tract. These are the palliative procedures which can be offered in case we are not able to offer the surgical correction. But what is important is to manage the cyanotic spell. Any precipitating cause needs to be ruled out. Not all cyanotic spells becomes an indication for surgery. Look for the associated cause. Is the patient having dehydration? Is the patient is anemic, which is leading to cyanotic spell? Look for the precipitating cause. If you can treat the precipitating cause and buy some time, it is always good. Clinical examination is very important. If you are having a very good ejection systolic murmur and good antegrade flow, and the patient is having a cyanotic spell, that means there has to be some other cause. With a good antegrade flow, a repeated cyanotic spell, look for a precipitating cause. Is the patient anemic, dehydrated, and having tachycardia? All these things should be ruled out. Well, the treatment is propranolol, beta blocker, and management is to look for the airways, position the patient. Morphine is the treatment of choice. Collect underlying hypovolemia, correct acidosis, and start beta blocker. Beta blocker might give you enough time to actually delay the surgery. And in fact, metoprolol infusion 1 to 5 mics per kg per minute may be given to prevent the cyanotic spell. Acute spells may be managed by Dilzam, steroids, mannitol, and persistent spells will require general anesthesia, ventilation, and an immediate surgery. Something like TGA. TGA, most important is stabilize the patient first. Look for all the other causes which could destabilize the patient. Volume, anemia, start prostaglandin, supportive therapy, may consider BAS, and the treatment is purely surgical. TGA treatment is surgical, and it is definitely should be done before the left ventricular regresses in less than 4 weeks of age and standing beyond 3 months. I think I'll finish in 2 or 3 slides. So TGA, if it is delayed, then if it's a VSD, we can delay it to 6 to 8 weeks. Alternatively, we can ban the patient or consider make the patient train the LV and go for arterial switch operation. For us, last part, which is single ventricle pathway. The surgical plan is essential surgical. We need to redirect the systemic venous blood to the pulmonary circuit. For newborn, we will either do a PA banding or a BT shunt. Otherwise, a venous rerouting with a Glenn at 6 months and a Fontaine at 2 to 4 years of age. So, I would like to conclude that most congenital cardiac lesions are amenable to surgery or catheter interventions. Timely evaluation, medical management intervention is crucial for long-term results. Thank you.